Good morning, everyone. My name is Shavina. I'm one of the ENT registrars here at the University of Cape Town. And today our talk is going to be an update on Reinke's edema. I have no conflict of interest, and I did get consent from the patient for the case history. So we have a 64-year-old female. She's a known hypertensive type 2 diabetic. She's also got dyslipidemia and atrial fibrillation. She's not on warfarin for. She's rate control. She's got a more than 30-pack-year history of smoking cigarettes, and during our first consultation with her, she still was smoking. And her main complaint was that she had worsening dysphonia. She's had it for about 3 years, and hoarseness. But over the last year, she noticed that she had decreased epic tolerance, getting worse over the last 6 months, but doesn't report any stridor, and she didn't have any stridor on consultation. We did a flexible laryngoscopy for her, and as you can see, she had grade 4 Reinke's edema with bilateral polypoid lesions, as well as obstruction with the medial borders in contact with each other along essentially the whole length of the vocal fold. So during our first consultation, she was also found to have laryngeal pharyngeal reflux, and she was started on a PPI as a pre-op. She did stop smoking about 2 months before the surgical procedure, and she was taken to theatre for microlaryngoscopy and a reduction glottoplasty with cold steel. This picture here on the top right shows what her vocal cords looked like after reduction during surgery. And the bottom picture shows what her vocal cords look like 2 weeks post-surgery. So she still has some residual Reinke's edema on both cords, mainly the anterior third. Unfortunately, she did report that she went back to smoking about a week after surgery, but she said she's going to try very hard to stop smoking again. So we haven't seen her again for her 3-month follow-up, so we're still awaiting that. So what is Reinke's space? It's the subepithelial compartment, which is situated between the mucosa of the true vocal cords and the vocal ligaments, and is essentially the superficial lamina propria, which covers the vocalis muscle. Reinke's space is on average thickness about 0.3 millimeters. It's actually a potential space that contains loosely interwoven collagen and elastic fibers. Hirano was one of the first to describe Reinke's space, and he described it as composing of amorphous substances that is loose and pliable, underlying the epithelium, which allows laxity and lax movement of the overlying mucosa, which helps in phonation by giving rise to a mucosal waveform. Reinke's edema is also known as polypoid chorditis or polypoid laryngitis of the vocal fold, and is often as a result of chronic inflammation resulting in vascular congestion and swelling of the superficial lamina propria of the vocal cord. Now, during the late stages of Reinke's edema, the polypoid degeneration of the vocal cords result in the edema being less. However, it is replaced by this 5 receptor that causes the polypoid appearance of the vocal cords. And this results in the excess mass that's often seen in higher grades or higher types of Reinke's edema. And this excess mass results in a disruption of the mucosal vibratory function, which results in a loss of pitch control and essentially a rough or hoarse voice. It's quite rare. It occurs in less than 1% of the population, and it's usually prevalent between the 5th and 6th decades. Up to 80% of patients are female, and nearly half of those is between the ages of 40 and 59. Why Reinke's edema preferentially affects females is not clearly understood, but an hypothesis that has been brought forward is that essentially females have a higher amount of hyaluronic acid within the vocal fold, and as a result have a higher increased uptake of hyaluronic acid, which is often found in patients with Reinke's edema. Also, some people say that female patients so are more likely to self-perceive voice differences and therefore are more likely to seek care. The main risk factors for Reinke's edema is smoking, phonotrauma, and pharyngolaryngeal reflux, with smoking being the most significant one. So there, throughout the literature, there's been several classification systems for Reinke's edema. One of the first ones was Yonekawa, which is one of the first ones that was put forward. And basically this one looks at the morphological features of the vocal fold during indirect laryngoscopy. And he proposed 3 different types. Type 1 being edema of the superficial aspect of the vocal cord, type 2 being edema extending to the posterior portion of the vocal fold, and 3 being massive edema. But the newest systems and the ones most quoted in the literature these days are the ones by Tan et al. And more recently, De Vincentis et al. So Tan et al. Is the one that looks at airway obstruction as the primary classification, and it classifies it 1 to 4 grades. Grade 1 being where the lesion is involved in less than 25% with only marginal edge edema. This table on the left here was taken from Scott Brown, just describing Tan et al. With grade 2 being 25 to 50% involvement, grade 3 being 50 to 75%, and grade 4 being more than 75% obstruction by the lesion. But the more recent one that is described by De Vincentis et al. Basically looks at the morphological and the obstructive characteristics of Reinke's edema. So you can see in this photo in A, labeled A, this is a type 1, where you've got Reinke's edema of just 1 vocal fold. The picture in B is type 2. This shows Reinke's edema of both vocal folds, C is type 3, where you have Reinke's edema on one of the vocal cords with a polypoid lesion, not necessarily on the same side as the Reinke's edema. And then in type 4 is where you've got Reinke's edema, which is D here, Reinke's edema of the vocal folds with polypoid lesions bilaterally. But that's the most common one used in modern literature. So just looking at the brief pathophysiology, there's still a lot of literature emerging on trying to understand the pro-inflammatory and pro-cytokine processes involved in Reinke's edema. But essentially, the main central feature is chronic irritation. And this can be chronic irritation from smoking or acid reflux. And this ultimately results in capillary permeability, which leads to edema, as well as polypoid degeneration of the true vocal cords. Typically, the cords look swollen and translucent. And it is important to distinguish this between other types of acute edema of Reinke's space, one of them being traumatic laryngitis. It's also one of the more common causes of dysphonia, and this is caused by an acute accumulation of fluid in Reinke's space. Not to be confused with Reinke's edema, where in the literature it's synonymous with the concept of chronicity. So it's chronic irritation that results in the expansion of the subepithelial space, and as a result, hypermobility and instability of the vocal fold, which results in an unmodulated voice and hoarseness. Just a mention about malignancy risk. As we know, tobacco exposure is a risk factor for both Reinke's edema and cancer. Given the almost universal prevalence of smoking in these patients with Reinke's edema, there is a thought that coexistence of invasive squamous cell carcinoma or dysplastic changes might be expected in a significant portion of these patients. However, to date, there has been several reports in multiple populations that show that the prevalence of coexistence between dysplasia and Reinke's edema is actually quite low. And there's no statistically significant correlation between identifying Reinke's edema and the type of Reinke's edema, whether it be type 1 to type 4, and the severity of dysplasia. Just other thing to note is that, imaging is not indicated in Reinke's edema. However, in patients where you suspect that there is a potential number 9 lesion, and those with subsequent treatment and follow-up PET-CT scans, there is a high incidence of false positive uptake on PET-CT with patients who have Reinke's edema. And so the caution in the literature is that if it is picked up on PET-CT, that ideally you want a laryngoscopy examination and often histopathology to determine if the PET-CT findings are valid. So primary medical approach involves elimination of environmental risk factors. These include smoking cessation, voice therapy, and the treatment of LPR being laryngopharyngeal reflux. And really, the main reason for doing these lifestyle changes is to prevent regression, to prevent continuation and recurrence of disease. No cases to date in the literature have shown that using these interventions alone results in regression of the Reinke's edema. In other studies, it has been shown that voice therapy doesn't really have a role in the primary management of Reinke's edema, but rather in improving the patient's use of their voice after evacuation of Reinke's space, and thus preventing recurrence of Reinke's edema by correction of faulty vocal behavior. So really the role is pre and post surgery. Other therapies that have been described in the literature is that of intralesional injectables, which can either be done under general anesthetic or as an outpatient in the office under local anesthetic. And the two main steroids that are mentioned in the literature is dexamethasone and the triamcinolone, which is said to have anti-edematous and anti-inflammatory effects. Although Reinke's edema is known to not be an inflammatory disease, the mechanisms of how these steroid injectables as an anti-inflammatory effect reduce the bulk of disease is still not known. Other literature have also shown the use of hyaluronidase, which is essentially a hyaluronic acid inhibitor. It's really used to treat Reinke's edema by enzymatic degradation of excess hyaluronic acid, which is often seen in patients with Reinke's edema. And it can, in type 1 and type 2, be quite a useful treatment to avoid surgery. I looked at one of the very few systematic and reviews and meta-analysis looking at intralesional steroid injections. Here, Wang et al. In 2012 looked at about 6 articles that were identified with a total of 321 patients. These patients all had type 1 to type 2 Reinke's edema, so very small lesions. And all of the studies reported significant improvement of voice outcomes after injection. And most of the adverse effects that they reported included local hematoma and some mild vocal vocal fold atrophy. They had about a recurrence rate of between 4 and 31%. But in general, it's demonstrated the two main improvements, that being in maximal phonation time and also in the voice handicap index, with a decrease in score of up to 27 points. So this is quite a viable option for patients who have a smaller disease, who have multiple risk factors that prohibit general anesthetic. Now, surgical interventions, the mainstay treatment for patients with not only type 1, but up to type 4 disease. And the principles of surgery here is really to reduce the bulk of the mucosa of the vocal fold while obtaining a straight mucosal edge and avoiding damage to an exposure of the underlying ligaments. It's really to remove all of that bulk without causing scarring and wound formation. There's been several surgical options proposed in the literature. These include cold steel, that being the original technique described, as well as CO2 and photoangiolytic laser-assisted microsurgery, microdebrider surgery, and also more recently radiofrequency coblation. So I'll try and briefly go through all of these, just giving an update on what the latest literature is regarding each of these surgical modalities. However, just to note that these methods have not really been conclusively determined to be superior one to the other in terms of voice improvement, and depending on which center you work in and what the skill set of your surgeon is, will depend on which technique you prefer. So looking at cold steel, this technique was first described initially by Hirano, and essentially involves an excision that's made into the laryngeal mucosa, overlying the superior aspect of the true vocal cord in its long axis. Reinke's space is then entered, and the submucosal fluid contents are aspirated, and the mucosa and the excess mucosa is then trimmed. Some people put in a stitch as well, just to try and get continuity of the medial surface, but some people don't. So it really just depends on your preference. And the literature has shown that this approach preserves the vibratory edge of the vocal fold by going through the superior aspect of the vocal cord. And the incision is made as far lateral to the medial or the phonatory surface of the vocal cord. And this technique has shown to decrease the mass of the vocal fold and widening of the glottis, and still improving the aerodynamic conditions of phonation. And this is currently is the most quoted technique in literature, and is essentially the standard at the moment for this type of microsurgery. Looking at laser. Laser surgery can be performed quite quickly and safely, and is often reserved for in-office use under local anesthesia. The procedure is usually quick and safe. It avoids the general anesthetic and sedation of the patient, and also allows the patient to go home the same day without the burden of anesthesia and a hospital stay. And essentially how the laser works is it provides selective destruction of blood vessels within the vocal fold with minimal thermal damage to the surrounding tissue or the overlying epithelium. Just to mention that patient selection in-office laser micro excision is crucial. Patients must be able to sit upright in an examination chair without the benefit of supplemental oxygen and with no monitoring. They need to be able to tolerate the nasolaryngeal scope with minimal anxiety and gagging. And one of the relative contraindications for this procedure is those patients with advanced pulmonary disease, who tend to adduct the true and false chords during expiration to provide some autopositive index vibratory pressure. And this results in excessive movement of the vocal fold, which makes the laser reduction quite difficult. And so this is the one patient you wouldn't want to try laser in the office with. So how it works, I've just put up some illustrations just to show you. So initially, you would do a transtracheal injection of a topical lignocaine. The needle is usually inserted about 1 centimeter inferior to the cricoid cartilage, around the level of the second and third tracheal rings, and the injection is given. And then looking at the picture on the left-hand side, there is a working channel nasal laryngoscope, which is introduced transnasally and brought into position at the laryngeal inlet. And then the laser fiber is advanced about 2 to 3 millimeters past the tip of the scope. And then in the last picture, you can see that the laser fiber is advanced near the laryngeal lesion. And the aiming beam, which is illustrated here by the little dotted spot, helps to target the lesion. Now looking through the literature, although laser surgery is quite widely used, both in the office and under general anesthetic, there have been some questions around the potential risk for heat dispersion damage to the surrounding healthy tissue and scarring. Also, if one is planning to use a CO2 laser under general anesthetic, it does require a larger medical team and requires obviously the inconvenience of procedural costs and overnight hospital stay. However, the newer lasers, being the KTP laser and the blue lasers, those can be used quite safely in office use, and so they are more popular than the CO2 lasers. Looking at this is probably one of the biggest systematic reviews and meta-analysis looking at office-based laser therapy. So here they specifically looked at the pulse KTP laser, the thulium laser, and the blue laser, which are all photoangiolytic lasers. They identified about 650 articles in this meta-analysis, 6 of which met the inclusion criteria. And so in total of those 6 articles, there were about 58 participants. And the study looked, like I said, at the pulse KTP laser, the thulium laser, and the blue laser, which is the latest laser used. And they looked specifically at voice outcomes and the lesion evolution through direct flexible laryngoscopy. They also measured the voice handicap index, and they used acoustic analysis and aerodynamic measures as well. And overall, in the 6 articles, there was a significant improvement specifically in the voice handicap index scores, and a significant decrease in the lesions, both at 3 and 6 months post laser excision. So using the photoangiolytic lasers in the office seems to be quite a popular but also relatively safe choice for clinicians. More recently, people have been using microdebriders, and this has gained quite a lot of popularity due to the oscillatory knife. And essentially, this can be gently inserted into the Reinke space and essentially gentle removal of the gelatinous material. There's adjustable suction pressure as well, so it offers a less invasive approach, and it does definitely preserve the underlying lamina propria and vocal cord ligament. This was one of the biggest studies looked at specifically a microdebrider versus cold steel. They They saw about 30 patients during the study. It was a retrospective study, so that being one of the limitations. And all of these patients were randomized into either Microdebrider or cold steel techniques. All of these patients had what they called sandwich speech therapy strategy, which is essentially patients got it 3 weeks before surgery, had speech therapy, and then subsequently 6 weeks after therapy, continued with speech therapy and voice rehab. Looking at the picture on the left-hand side, this is just what the technique looks like. So in A, essentially this is the excision of the edematous vocal cord, and here we use cold steel initially to make the incision into Reinke's space. Picture B shows the insertion of the tip of the handpiece into that space. And C shows the microdebridement of the gelatinous contents of that space. And then D is what the post-op picture looks like after removal. This technique is quite favorable because it does decrease the amount of bleeding during the procedure. And it did show significant improvement in vocal parameters in both groups, that being cold steel and in the microdebrider group. But the nice thing about this technique and what the authors highlighted is that in patients where you have difficult conditions and poor visualization of the glottis, this technique is found to be far superior than cold steel. And on the right-hand side, this is a table taken from the article showing in which scenarios the microdebrider is superior to cold steel. So that was the conclusion in this article, is that essentially in patients with difficult exposure or where you don't have a microlaryngoscopy tube for intubation and you have to use a normal endotracheal tube, this technique is quite favorable. Looking at radiofrequency coblation, this is an emerging technology that can cut soft tissue and provide hemostasis at the same time using lower temperature levels. The radiofrequency coblator operates between about 40 and 70 degrees Celsius, and this has been proven to cause minimal surrounding tissue damage and preserves the integrity of the surrounding tissue, unlike that of CO2 lasers and angiolytic lasers that can result in thermal injury. In addition, the radiofrequency also simultaneously does coblation, cautery, and hemostasis, and does suctioning function as well. So the advantages of this technique is that it eliminates the need for multiple instruments, and as a result shortens the operation time and surgical time. Now, any considerations, especially in resource-limited countries, is that it's very expensive and there is a steep learning curve with this instrument. So this would make, you know, this type of technology not freely available to all physicians. This is just showing the technique of how you would use the radiofrequency coblator. Essentially, what you would first initially do is burn the mucosa along the total length of the vocal fold. Once you have opened up that mucosa, essentially you place the coblator into the Reinke space, and through the suction feature of the coblator tip, you're able to suction that the contents out. This is probably one of the only validated studies at the moment, looking at cold steel versus radiofrequency coblation. It's a retrospective study, and it looked at patients with the type 3 and type 4 Reinke's edema. They were all either treated with cold steel or radiofrequency coblation. And essentially what they showed, it was about 33 patients in the cold steel group and about 28 patients in the radiofrequency coblation group. The only real advantage of the radiofrequency coblation compared to the cold steel group was that the post-operative voice evaluation, so that's the GRBAS, so that's the grade, roughness, breathing, breathlessness, aesthesia, and strain scoring system, was slightly better than the cold steel group, although this was not statistically significant. They also showed that the vocal fold symmetry, wave, and glottic closure scores were much better in the radiofrequency coblation group than that of cold steel. And there's a lot of these patients went to voicing quite quickly after surgery with significant improvement in the voice quality than compared to the cold steel group. However, the decrease in the voice handicap index scores and the acoustic voice parameters, they showed no significant difference between cold steel and radiofrequency. So both of these, so the article summarizes that both of these options are viable, however, with radiofrequency having the advantage of less bleeding and better visualization of the glotis, as well as decreasing the surgical time. So just to conclude, the treatment methods and modalities, there's a lot of them out there. There's no real consensus on which is more superior than the other. There are multiple, very small studies showing slight significant differences in between these specifically surgical interventions, but none really showing to outshine any other with regarding voice handicap index and the acoustic parameters. So really the modality and method is really dependent on provider comfort and training and the availability of equipment within the different hospital centers. There are no specific established guidelines for treating this disease process, and results may vary across different institutes because different measurement parameters are used pre and post, and not everybody uses speech therapy pre and post. And so a lot of these studies, you can't really do direct comparisons with each of them. Importantly, from my literature review, smoking cessation and management of coexisting LPR is essential as it has quite a significant contribution to the disease process. So addressing these two other risk factors is important in your general management of these patients and also to prevent recurrence of disease. And that really surgery should be done for all patients with advanced disease, and that being type 2 to type 4 with the intralesional injections and the environmental modifiers really being only for the very early or type 1 lesions. That's all. Are there any questions from the panel? There are quite a few people.